Welcome, everyone, and thank you for joining us for today's session on pioneering our understanding of the human brain. Please join me in welcoming Dr. Mark Richardson. Dr. Richardson has pioneered the neurosurgical use of interventional MRI, robotics, gene therapy, and closed-loop brain stimulation. He is also the founder of the Brain Modulation Lab, which conducts human systems neuroscience research using intracranial recording and stimulation. He directs the Epilepsy and Movement Disorder Surgery Program at the University of Pittsburgh Medical Center. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Dr. Richardson's talk title is Basal Ganglia-Cortical Loop Function During Speech. My name is Dr. Roshanak Hashemian, and I will be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. We would like to extend our special thanks to the Brain Initiative program directors, in particular Dr. James Nat, for their efforts in organizing today's session. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting your questions during the presentation. Simply click on the Ask a Question box located on the far left of your screen and type your questions in the drop-down box. Our speaker will respond to your questions by email following the presentation. This presentation is educational and thus offers free continuing education credits. Please click on the Continuing Education Credits tab located at the far right corner of your presentation window and follow the process to obtain your credits. Now, without further ado, please join me in welcoming Dr. Richardson.
Thank you for that introduction. This presentation is going to cover a relatively new area in invasive human neuroscience research, and that's the role of the basal ganglia in producing speech. So this project is funded through the Brain Initiative. It's part of a mechanism called Research Opportunities Using Invasive Neural Recording and Stimulating Technologies in the Human Brain. And the reason that's important is that this is an entirely new mechanism over the past several years that is really specific to opportunities that present themselves during neurosurgical cases where neurosurgeon neuroscientists and our teams are able to learn about the brain through things that we need to do with patients clinically while we're recording and then simulating from the brain. So this project specifically looks at the role of the subthalamic nucleus and the cortex and interactions between the two during speech production. It's a combination of investigators from the University of Pittsburgh, Carnegie Mellon University, and also Johns Hopkins. All right, so most models of language and speech production focus almost entirely on neural activity at the cortical level. And here's an example of different models. And one primary reason for this is lack of direct access to deeper parts of the brain. So through neuroimaging and through EEG, it's easier to get a readout on what the cortex is doing while someone talks. But it's very difficult through functional neuroimaging methods to get a read on what's happening at the subcortical level. And there's a lot of important network activity that happens there. And the reason we know that is that all of our actions are not mediated solely by neural activity at the cortical level, but rely on communication through basal ganglia thalamocortical loops. So here's a schematic of that, and this is showing loop for motor control, where you have signals that go from the cortex into the striatum, back through the thalamus to cortex, and this occurs in segregated loops. Here's one for more executive function, and here's another for potentially more limbic or associative functions. And these networks are separated for the most part. Obviously, there's some integration so that we can coordinate emotions with motor behavior, for instance. But these pathways are also used in speech. It's just that there haven't been really good ways to study this in the past. So we know the basal ganglia participate in speech because the basal ganglia participate in all motor and cognitive actions. But specifically, speech is disrupted in Parkinson's disease and in other disorders of the basal ganglia. And specifically in Parkinson's disease, this can result in a number of problems that make it very difficult for patients to communicate. They lose loss of ability to impart emotion to their speech. That's called prosody. They have some purely motor articulatory problems. They have a significant issue with hypophonia, so that's volume control. And then one side effect from DBS, we really don't know why it happens, but it's probably the most common side effect from subthalamic nucleus DBS is a decrease in verbal fluency. So with all these issues for Parkinson's patients, medications don't work very well, and DBS can work for some motor aspects of speech, but sometimes it can make other aspects worse. So there's real need to understand this better, and our team, in fact, works with patients that are undergoing deep brain stimulation for movement disorders like Parkinson's disease and essential tremor. Briefly, DBS is a platform for delivering small amounts of electrical current to specific parts of network that's affected in movement disorders. That electrical impulse is controlled by a battery or pulse generator. It's essentially a small computer, which usually resides in the chest. And this is what it looks like up close. So this is its real size in relation to a dime. There are different models now that have more than these 4 contacts, but we can both stimulate through these and we can also record off these electrodes. And then as part of the surgery to implant these electrodes, patients are traditionally awake. And therefore, we have the opportunity to ask them to do things like speak while we can record from various structures in the brain that are involved in the speech network. So deep brain stimulation surgery is really the only opportunity to record neural activity in the human brain directly from basal ganglia structures. There's not any other clinical indication currently for putting electrodes in these areas in awake patients. This is what it looks like for a DBS patient in the operating room. Here I'm working with my physician assistant and a resident surgeon. Here's the patient who's comfortably positioned with a stereotactic frame, and we're doing some motor testing in this case. But we have learned to take advantage of this opportunity to look at speech. And this is an overview of how we're doing that. So specifically, we're interested in the role of the subthalamic nucleus and how it interacts with the cortex. And there are a couple reasons for that. One is opportunistic in that we quite often implant the STN for DBS and Parkinson's disease. But the other is that that's the one structure in the basal ganglia pathway, at least downstream, that's directly connected to cortex through the so-called hyperdirect pathway. That was pictured in the schematic previously. And so through introducing stimuli, which can be words that are read or spoken to the patient, they can hear them in headphones. We can look at what's happening in the brain when this stimulus is produced, a cue to speak. We can look what happens during the production or output of speech. And we can also, in the third panel on the right, we can use electrical current to disrupt different aspects of speech production based on predictions that we generate from a model we can develop from data that we obtain from recording in these brain regions. So again, here's a schematic. You can see the hyperdirect pathway coming to the STN, and initially our work is focused on motor loop for speech. Here's another schematic of what the experimental setup looks like. So we typically would insert 3 electrodes into the subthalamic nucleus as part of the brain mapping portion of the case in order to determine that we're in the right spot. And it's routine to do this with patients awake so that we can test them and we can get a signature of the subthalamic nucleus that we can use to make a determination that the electrode is in the right spot. So these clinical electrodes record single units from the tip of the microelectrode, and then there's a ring contact to record local field potentials, which is 3 millimeters above the tip. We can also, through the burr hole, which you can see depicted as kind of the ring around the leads at the top of the cortex, we can insert a soft, flexible strip electrode, and in our case, we use a 63 contact micro ECOG array that's very easy to slide over the cortex, and we have a method of aiming this stereotactically in the operating room. For the sake of time, I'll just show you some images so you can see what this looks like. And here's a patient, again, positioned in the operating room with the stereotactic frame. In this case, there's a microphone, boom microphone that's positioned in front of the patient's mouth, and we have the same setup each time. And then the research team is watching the presentation. You can see TA that's on the monitor on the right upper panel, and you can see the purple kind of squiggles that are the word that the patient's hearing. Then we also see their response, and we're recording that data at the same time we're recording, if you look in the lower panel on the right, those are single neuron spikes, and so we're recording single unit activity. That's our clinical recording system, and we're recording local field potentials at the same time. All right, here's an image of what one of these electrodes looks like. Really soft and flexible plastic, you can see that. So actually our NIH U01 consortium is just writing up a safety paper. If anyone's wondering, is this safe to do? This has been done now in hundreds of DBS patients without any complications related to placement of the electrode. So we feel like it's really safe, and it's also, we think, this is somewhat of an aside, a precursor to a time when we may be implanting sensors like this along with closed loop DBS devices, so that devices are reading from the cortex and using that information to decide how to stimulate at the subcortical level. If you look at the panel on the right, this is a representation of what we can see in real time in the operating room, so we can verify that using gamma activity related to speech onset that we're recording in the right spot. And then this is ad hoc, a representation of gamma activity on the cortex on the right side of that right panel. The next slide is going to show the behavioral task, at least the one I'm going to talk about today. So a few slides back, I showed the schematic of the electrode over the cortex, and I didn't mention it then, but indicated on that slide is the fact that we can record over M1, S1, and also this superior temporal gyrus, so auditory cortex. First task that we set up, and for which I'm going to show you data today, was a reading task, but currently we're engaged in an auditory repetition task. So we can look at how the information from the STG participates in basal ganglia-cortical loop activity. But this is what the behavioral task looked like for the data I'm going to show you. So there were a series of words and non-words that were presented on a screen. The patient read them. Okay, well, what have we found thus far? First interesting thing is that subthalamic nucleus neuron activity is dynamic during speech production. So there's not just one thing that's happening. That's not unexpected from the literature about STN function in general. Much of that literature is from non-human primates and movement, and then some of that literature is from cognitive task work in humans. And there's really a debate about what the STN, the basal ganglia, do in general. But one thing we can say is that firing rates both increase and decrease relative to the onset of speech. This is a plot of many different neurons, and whether there was an increase or decrease and when that happened in the firing rate. And then this is an example on the left side, the upper side of a neuron that increased its firing rate, and one that decreased its firing rate is on the bottom. And you can see that that decrease actually happened before the onset of speech, which is time 0. You can look at this paper in Journal of Neuroscience if you're interested in seeing this in more detail. For the time being, I'll show you this figure from the paper, which makes a point that firing rate increases were more likely to be locked to the actual onset of speech, while decreases in firing rates were more likely to be locked to the cue. So some cognitive planning aspect of speech production, at least that's a hypothesis. So you can see the firing rates on the left side of these panels are aligned in relation to cue. And then you see in the second panel the relationship to the firing rate increase or decrease and the production latency. And then the panel on the right shows the correlation coefficients of the production latency for those that, for each neuron relative to production interval. And then it's color-coded based on whether the neuron firing rate increased or decreased. And what we found was essentially that Q-locked decreases in firing rates were common, and production-locked increases in firing rates were common. So we're working our way through what we think that means, but there appears to be some dynamic coding of speech in the STN. So next what we did was move to looking at what's happening in the cortex at the same time. We've done that so far with local field potential recordings from each area. So this is the first study where anyone has ever recorded from the subthalamic nucleus and the cortex at the same time. This was also recently published in the Journal of Neuroscience. And these are images just showing an overview of where we recorded. The next slide will show some of the data. So we were interested in this question of whether or not there is any specificity for articulatory features and neural activity in the STN. So we know from the work of others that there's topography for this, and the sensory motor cortex, that's SMC, and the data on the right. And we know that this can be tracked with gamma activity. We know there's a beta desynchrony before the onset of movement or speech. But we found something similar in the subthalamic nucleus as well. If we look actually starting on the right, just to orient to the cortex, which most people are more familiar with, you can see in the panel that's showing the volume basically over which we recorded, that there's a topography for where lips in red are recording locations are separated from tongue in blue. And then you can see the time frequency plot on the right, plots on the right. And then you can also see two examples, one where tongue was differentiated from lips, that's top one, and then where lips was differentiated from tongue on an individual contact at the time of speech onset in terms of the high gamma activity. So some selectivity for the articulatory feature, lips versus tongue. And we found something similar in terms of being able to differentiate this at the individual contact level in the subthalamic nucleus based on high gamma activity. But the difference is that there didn't seem to be a topography for that. We are also working our way through what we think that means. These areas that were selected really do appear to be scattered about. It'd be helpful if we had even more recordings, and we do have more recordings, and so we're looking to replicate this finding in some of our newer data. Okay, so some additional findings that I'll just mention for the sake of time. So we've also found that subthalamic nucleus activity and activity in the cortex tracks with gain adjustments during articulatory movements. And this is measured in the speech and speech pathology field by the Foreman ratio. So we see some correlations between actually lower frequency oscillatory activity, not high gamma activity, but lower frequencies that track with Foreman ratio on a per patient basis. The data that I showed also suggests a role for the subthalamic nucleus in speech planning because we see STN activity that occurs prior to the onset of speech. This isn't entirely surprising because we know that the basal ganglia participates in motor planning. It's really not clear how, however, and what specifically is being done and what cortical areas are influencing various parts of the STN on a functional level that we can appreciate in the operating room. And the reason this is important is because as we think about how to develop new DBS therapies, we need a better understanding of how and where information is traveling through this network. And then some really tantalizing new work that's not ready to show in this presentation, but we also run this task in patients where we can report from the thalamus, and in fact are seeing a laterality effect in terms of discriminating words and non-words based on neural activity in the thalamus. So that wraps it up. I just mentioned this, but the overall goal of this work is to build a better neurological framework that will allow us to improve deep brain stimulation for disorders like Parkinson's disease and other basal ganglia disorders where speech communication becomes a real problem for patients. Thank you.
Thank you, Dr. Richardson, for that innovative presentation. As a reminder, our speaker will follow up with any questions about his presentation via email. Coming up next, please join me in welcoming Dr. Juan Barcia, who will be discussing his groundbreaking work inducing cortical plasticity by brain stimulation and prehabilitation. Hope to see you there.